Started. I'm very pleased today to introduce a speaker that has been quite a contributor to our center and to this geriatric series every year. Emily Trittschuh is a clinical neuropsychologist and associate director of education and evaluation with the VA Puget Sound Healthcare System's Geriatric Research Education Clinical Center. She's also an associate professor in the Department of Psychiatry and Behavioral Sciences at the UW School of Medicine. She has specialized in neurodegenerative disease and geriatrics throughout her career. Her clinical work and research has been focused on a full continuum of cognitive aging, from dementia to superaging into the 90s and beyond. Since joining the VA, she has developed an additional and complementary interest in the care of older veterans with PTSD and cognitive concerns. And we're very fortunate to have her talking today about the four M's, and specifically the age-friendly healthcare M of mentation. Welcome, Dr. Trittschuh.
Thank you so much for having me. I really appreciate it. I will go ahead and jump in. I do have a slide here in terms of disclosures and acknowledgements. I have no financial disclosures, and as always, the views and opinions in this presentation or that I might express as a presenter should not be taken to reflect as policy of the U.S. Department of Veterans Affairs, for whom I work, or the University of Washington, for whom I also work. I do want to give a shout out to my colleague and a GRECC Associate Director of Education Evaluation in a different VISN, who was also the co-developer with me for the Mentation module of the GRECC Allied Health Geriatrics core curriculum, Beth Hogans. She's with the VA Maryland and Johns Hopkins School of Medicine. So I pulled a few slides from the curriculum we put together for that. I also want to make a land acknowledgement, but I won't read it again since I feel appreciative that you covered that already. So what is our Northwest Geriatrics region? And for me as a VA employee, what we call VISN 20, well, we've got the states of Alaska, Washington, Oregon, Idaho, Wyoming, and Montana. I pulled some Census 2010, Census 2020 versus the projections that were created, just to highlight that this is, we have an aging population for folks that are, and in this case, they defined older adults as 65 and over, but over time and time again, we are seeing that the projections are falling short of the actual aging population. So as you can imagine, we need to be thinking about how are we going to provide care for this increasing and changing demographic. And I want to emphasize, just take a moment, the changing piece of that, in that newer generations of older adults are more diverse and have different needs and that need to be accounted for versus some of the previous generations. So as you can imagine, there's always a need for geriatric specialists, for folks across healthcare disciplines that are particularly interested in geriatrics and have done advanced training in that area. But that is not going to meet the need, not by a long shot. Is the need going to be met by primary care providers? Yeah, they're going to carry a lot of the load, but with the numbers of older folks and the time limits for encounters, they can't meet the need alone either. So what we have at the VA is called a patient-aligned care team, a PAC team, but there's many other names for these types of teams across different healthcare settings. And basically, this is this group of healthcare professionals, as well as administrative folks, who work as an interprofessional team to meet the needs of the folks that come to that clinic. And I'm hoping that given the significant consequences of declines in mentation that are more likely to affect older generations, we will have a paradigm shift so that the top disorders, especially of aging, those that affect mentation, are, if they're not already, are definitely going to become a regular part of the workup and the diagnostic differential for patients. So I'm just a huge proponent, especially with my background as a psychologist, for a healthcare team approach. And I'm hoping everyone here will want to adopt that as well. I probably don't need to spend too much time on this slide since Dr. Cochran covered it, but we're kicking off the spring ADRD, so that's Alzheimer's disease and related dementia series, with this talk on mentation. Of course, it's important never to forget about the other that greater aspect of aging in healthcare and the other pillars of the 4Ms framework. I was going to talk a little bit about each, but I think we kind of hit on those. Each of these, though, interestingly, does have some dependence on mentation. They are interrelated. So for medications, being able to take medications properly, getting refills on time, accurate reporting of side effects, positive effects, those all sort of rely on thinking ability. Also, mobility at first might not seem as related to mentation, but think about it. If you have a new physical challenge, the ability to learn new routines for safety that will help someone maintain independence, those are often very reliant on mentation. Also, unfortunately, reduced mobility can lead to social disconnectedness, and that is a risk factor for aspects of mentation, mental health, as well as cognitive health. So I highlight mentation there. Now I need to figure out how to get my notes to change. Okay. And then, of course, what matters. That's at the top of this framework. And it needs to be I shouldn't have to remind anyone, I'm sure I don't, that this isn't about our healthcare individually. What we're focused on is the person in front of us and what matters for them. It's no use of us to make big recommendations without connecting it to why that's important to someone. And there may be times where what we think is the number one priority is not their priority, and we have to work within that framework. Okay, so mentation, particularly thinking about mentation and aging, this talk is going to describe mentation. I will be giving you words to verbalize what dementia is and what it's not. I think you'll also come out of this really appreciating the importance of mental health as part of mentation, especially depression and aging, and hopefully with some more tools to identify and prevent delirium, especially appreciation of some of those key features. So mentation. Mentation comprises both cognitive function and mental health. Talks I've given in the past have really focused on the 3 Ds of aging. That's delirium, depression, and dementia, because those are 3 of the most prevalent conditions in aging that can affect mentation. In order to think about what is maybe not quite right in mentation, it's important to understand maybe what the typical changes are that one might see in aging, and I'll go over those. Also, we need to be able to recognize red flags for changes in mood or thinking. And then it's also important to appreciate how mentation can support independence in daily function for older adults. What is typical cognitive aging? Now, here I'm going to do it. I'm trying to say typical because we sometimes fall into the habit of calling it normal cognitive aging, but that really, unfortunately, suggests that everything else is abnormal. It's so cut and dry, but it's not. It's important that we try to appreciate that heterogeneity in cognition with aging is actually pretty high. And so someone starts with their baseline abilities, and changes can be small, can be large. Depending where you start, it can have a small or large impact. Some things that we do know about typical cognitive aging is that we should not expect to see changes in one's own autobiographical memories. Who was my first grade teacher? Where did I grow up? If I'm a military veteran, where did I serve? What branch of the military was I in? We also do not expect folks with aging to have difficulty with the recall of well-learned information. Sometimes there could be a little tip of the tongue phenomenon where they can't quite get the word quickly, but that information should not be lost. Also, procedural memory. How do I brush my teeth? How do I drive a car? These are things that are just ingrained into me with essentially behavioral routines and procedures, and those typically are not lost with aging. Also, emotional processing does not usually notably change, and despite the stereotypes and ageist perspectives we have that people sort of become grumpy when they get older or mellow out or things like that. That's just more That's media that's telling us that. What we can see a decline in is the encoding of new memories. Folks might be a little slower to learn new tasks, might need a little more repetition. Kind of that, how much can you pull in at once, can decline a little bit. Also, working memory, the ability to sort of juggle many things at once, that sometimes can decline. And inevitably, we do see that processing speed slows a bit, not dramatically, but a bit. And that can make someone a little slower to catch on to or respond in novel situations. So here's another slide with data pulled and shown actually graphically over time. Those warm colors are things like world knowledge, and other just vocabulary, some verbal skills. Those actually go up most of our life, although there's kind of a point where it sort of evens out. But what you may be noticing are those cool tones, which are things like processing speed, working memory, and new learning, which are in decline. Now, perhaps you're noticing that the decline actually starts here in one's 20s and 30s. So thank goodness for the increasing aspects that our experience and wisdom are giving us. I do, just as a little side note, I think that some of the subjective concerns we get from people who are very attuned to their own thinking ability are sometimes come out when they're in sort of this range, the late 40s into the early 60s, when that cross point kind of first occurs, where they're not necessarily gaining new abilities, and then they become a little more aware of some of the subtle slow declines that have been happening. So quick knowledge check. This is, I don't have a really good way to do this because I can't see the chat, but I would love it if you all would throw things in the chat for your answers as to whether you think it's A, likely age related, or B, is a clear red flag for mentation. Can't recall major parts of one's own life story. Throw things in the chat there. See what people are saying. All right, that is a clear red flag. How about learning new tasks more slowly? How to navigate, say, let's say you get a new smartphone, something, a device you haven't used before. Well, that's quite potentially likely age related. Can't remember well-learned facts. Who was the first president of the United States? Oh, I hope you're all putting B's in there because that is a clear red flag. Okay, maybe some trouble with multitasking, having to talk to someone while you're also performing mental arithmetic. Well, that's likely age related. And I got to tell you, it's something I can't do anymore.
And it seems like everyone's pretty much agreeing with you.
Everybody's on it. I have things that are meant to be kind of at the far edges. And how about describing steps in a common task, how to mail a letter? That is a big red flag. Being a little bit slower to respond to new information, that's more likely age related. And then losing track of the emotional tone of an interaction, detaching quickly. That is a red flag. Okay, now, the reason we care about these is because not all changes in thinking with age are typical, right? I have here that everyone experiences some subtle changes, some more than others with age. But what we're worried about are the changes that may indicate the preclinical stages of dementia or mild cognitive impairment. That's the zone where there are objective changes, but they're not yet taking away independence and activities of daily living. And then, of course, what that often can signify, but not always, is that someone might be developing dementia. Now, not all changes in mentation, though, are dementia. And I want you to be sure you come away from this talk with that in mind. So one of the things, the area of cognition, or sorry, of mentation that isn't necessarily a red flag for dementia necessarily, would be mental health conditions. I'm going to talk mostly today about depression, but let's not forget about anxiety, which can be characterized by excessive worry or panic or stress responses. These often can result in sleep impairments, concentration difficulties. I, with working at the VA, encounter a fair amount of post-traumatic stress disorder, and there's some of the descriptions of that here. In fact, a lot of the symptoms of a flare in PTSD are cognitive. So that's not uncommon that I get someone at the memory clinic who is actually experiencing PTSD symptoms, but they're really concerned that it's early Alzheimer's. Also, older adults are not somehow immune from having substance use disorders. So this is a complex condition that could be associated with cravings or even just behavioral patterns that have sort of gotten out of whack or with aging have not adjusted downward to account for changes in our body composition and other things that occur with aging that make us more susceptible to the negative effects of substances. So we don't want to lose sight of these. And another important facet of mentation is that it's incredibly important for functional independence. There are many aspects of cognition that are essential for remembering to attend healthcare appointments, adhering to treatment plans, maybe managing household needs, paying bills. I've heard the government really likes it if I pay my taxes, right? Also being able to either manage one's own transportation by driving oneself or navigating alternatives to being the driver in a car. Mental health is also essential for functional independence. We need to think about if mental health usually helps support our caring for ourselves and our health, making good choices, maintaining positive relationships. Both of these are important for anticipating future needs, but kind of coming from different reasons. And then, of course, mental health helps us in our functional independence by avoiding conflict and legal problems. So these are some things that I heard in clinic. I hear them all the time, but I wrote these down when I initially started here, and they've stuck with me. Things like I can't focus. I have loved ones saying she's not interested in her usual activities, people having trouble coming up with the word they want, low energy. My favorite is a spouse saying that their husband's selective attention is worse. He doesn't listen to me at all anymore. Short-term memory, not being able to find a car in a parking lot, or maybe even something more concerning, like not being able to remember that different medication instructions were given. So I don't know if you've picked up on this, but these are all non-specific. They do not tell us whether it could be depression, delirium, or dementia. However, they are all red flags. So coming back to the dementia here, I want to emphasize that this is a decline in some aspect of cognitive function and or behavior, and that the tipping point, remember from mild cognitive impairment to dementia, is when that ability to compensate or juggle those tasks of daily living becomes too much with the cognitive ability decline and things start to get dropped. It could be finances, medication management, navigation, and more. A critical thing about dementia, though, is that this is a clinical syndrome and it has to have these four key features. It needs to be significant. I've mentioned the functional consequences. It needs to be chronic. Dementia doesn't get better. It has an insidious onset and a progressive course. Some dementias move faster, some move slower, but they don't get better, even though there may be some days that seem better than others. And it's always a loss. These need to be new impairments. If someone suffered a stroke, and had a decline in their thinking and behavior, and then it held steady, that is not necessarily dementia, or that is not dementia. If someone had a head injury and they have a new baseline, that is not dementia unless it starts to get worse over time. And dementia is based on some sort of structural damage to the brain, whether that's vascular systems, neurons. Eventually, it all impacts those workhorses of our brain, the neurons. Okay, what is dementia not? Well, it's a little cheeky of me to put the two other D's here, but dementia is not delirium, which typically has a more acute onset, attention and concentration problems. And it's not necessarily depression. It's not depression, sorry, which may be characterized by these other things. But usually, if I do a neuropsychological evaluation, those deficits are not objective on testing. It's not sensory deficits or communication problems, and it's definitely not normal aging. So what types of dementia do we have? Well, there are a lot. I have put here some of the more prevalent causes of dementia. Does anyone want to throw in the chat what they think is the number one cause of dementia, or the number one most prevalent type of dementia in aging? People might get shy now that they know I can't call out in the chat, but you're right. It's Alzheimer's dementia. And remember when I said that dementia is a clinical syndrome? Talking about the cause of the dementia is something different. So let me touch on that. There are three most prevalent causes of dementia in older adults. And when we talk about dementia, this is the syndrome here. So there's overall that umbrella term, dementia. And then underneath that, the most common type of dementia that's diagnosed is Alzheimer's type dementia. Second is vascular dementia. And coming in third is a Lewy body dementia. This talk is not going to go into detail about these three different causes, but it's important to understand that they have different etiologies. Alzheimer's disease is presumed to be Alzheimer's dementia is presumed to be caused by Alzheimer's disease pathology in the brain, vascular dementia by cerebrovascular disease and pathology in the brain, and Lewy body dementia by Lewy bodies, which are a certain type of pathology causing disease in the brain. There's a lot of work being done to identify ways to prevent Alzheimer's disease in the brain. But unfortunately, at this point, even if you attack those diseased particles, the pathology in the brain, it does not make someone not have dementia. Okay. So we're sort of still in a period where we want to think about prevention and early identification to help support patients. I also really want to emphasize early identification of red flags and good workup because there are many causes, there's many things that can kind of mimic dementia. And I hinted at, for me in my clinic, PTSD, depression, sleep apnea is a low hanging fruit for a lot of veterans come in and see me, and they either know they have sleep apnea and it's not treated, or they don't know that they have it. And when they get on board with treatment that's effective, usually it's CPAP, I have actually seen them back and seen what looked like an early Alzheimer's profile on testing go away, and they're doing better. There are other toxic metabolic causes and systemic illnesses that can mimic dementia. One thing I do warn, though, is that treatment of these conditions usually will improve, but it doesn't always fully reverse symptoms. That's sometimes because there's an underlying cognitive disorder that's maybe even led to the above. So treatment of the issue may not fully reverse that problem with mentation. These people need extra special monitoring to make sure that they don't end up declining again. And some of these causes, toxic metabolic, especially when they're acute, can actually be a cause of delirium. Let's go there next. So delirium. When I was in training, I had all sorts of terms. People would call it toxic metabolic encephalopathy, acute confusional state. But luckily, the field has really settled in on using delirium as a general term. It is a medical condition. It typically has a rapid onset. That can be, though, in minutes, and it can also be in days, and very rarely in subacute situations, maybe more like in a week or two. The primary deficits are usually attention and concentration. The tricky thing here is there can be waxing and waning in those deficits. So you'll be alarmed, think you need to take someone in, but then they seem a little bit better, but then they go downhill again, and eventually they will continue to go downhill. So it's important to act on this. Infections, medications, obviously not normal actions of medications, but either polypharmacy or overdosing. Those are the things and metabolic abnormalities that are the most common causes. One thing that's interesting is changes in mentation are actually sometimes the first symptoms, and they even can precede the objective signs of illness. Sharon Inouye is a Boston-based delirium research guru. I recommend anything she's ever done. And so this article from 2014 in Lancet was really important in recognizing how under-recognized delirium is. And what is delirium not? Well, it's not insignificant, and that's why I'm really trying to highlight this here. A number of studies, more than are here, but many studies have demonstrated time and again that there is significantly increased mortality for individuals, older adults, who develop delirium when they are then followed over 6 to 24 months. Delirium is not dementia. And delirium, just like I said, mentation can precede the objective signs of the illness. Mentation can also lag behind when the actual etiology has been addressed, the infection or things like that. So folks can be discharged from inpatient when their cognition is not fully cleared, perhaps even with complex instructions to home alone, things like that. So we always want to be thinking ahead for how to best support people so they don't bounce back, right? So we don't end up with them back in the hospital. Delirium is not normal aging. So there are lots of risk factors for delirium besides just age. In a review and meta-analysis, delirium was found in up to 40% of those who were hospitalized. And when they looked then at the pooled analysis for risk factors, dementia was really high in the list, as was the severity of illness, visual impairment, being catheterized, having low albumin, and not surprisingly, the actual length of their hospital stay. And another article from which I thought was worth highlighting, it was looking at just a hip fracture hospital sample. Some of these folks were not super old, but they found out of their large sample size, 35% had delirium. And again, we see dementia on the list, we see age, we see history of delirium. Getting delirium once seems to make you more susceptible to developing delirium again. There's a few other factors here. I won't read through them all. So just to go over it again, here's some of the ways to recognize delirium. I'd like to mention and emphasize this hyperactive or hypoactive. So that can be tricky. The hypoactive presentation, which also may be characterized by increased somnolence, that's that bottom one, could be thought that maybe someone's developing depression or a worsening depression. Okay, I'm going to go there next to talk about depression, but first, I want to throw out just a reminder of some of the places that folks who are delirious might show up if it's not caught at home. We always think of the emergency department. It could be the PACU, it could be a med surg unit. A lot of times people who are going through surgery require closer supervision and monitoring. It's really common in skilled nursing facilities and community living centers. It's also not uncommon in an outpatient clinic, especially if you've got maybe more of an urgent care setup, an option for clinic. Okay, so I said I would move to depression, and I'm not going to read the whole list here. Some of the things on the list might seem more obvious than others, like suicidal thoughts, while others may seem more subtle and not always recognized as signs of possible depression. Sleep changes, appetite changes. Depression is not just a bad day, week, or month. It's not normal grief or a natural reaction to health changes or loss. And depression is not a direct cause of dementia. I dislike the term pseudo dementia for depression because I think that it's a discredit to depression and it's a discredit to dementia. So it's important to try to avoid that term when possible. And really importantly, depression is not untreatable in older adults. So I threw in a little block here with some of the normative mental health and aging comments. You know, when you get older, you can have grouchy days, you can be in good spirit, and you can have new interests, and there should be persistence of personality. And normal mental health and aging should include positive self-appraisal, despite all the negativity out there about aging and the entire process. Recognizing depression, it can present as nonspecific physical symptoms. I've mentioned sleep changes and things like that, but it also can present as someone just having higher than expected pain complaints or GI problems or fatigue. Traditionally, older patients might be less likely than younger to admit to being depressed. Sometimes it's just about the verbiage you use. Ask people in more than one way about their mood. And this is because across all ages, depression is stigmatized, whether we like it or not. I find that it's important to ask about depression a couple different times, doing it maybe when a loved one is present, but then doing it again when they're not present, and maybe doing it verbally, maybe doing it in writing, using terms like feeling blue, feeling down, and trying to do both open-ended questions as well as yes/no questions. So in older adults, there are some studies that have shown that as many as 10% of older adults seen in primary care have clinically significant depression. However, that same research, similar research has shown that only about 10% of them receive treatment for their depression. Uh, Really useful is behavioral activation. A meta-analysis of 7 randomized control trials showed moderate intensity exercise reduced depressive symptoms. I want to emphasize also that younger and older adults respond equally well to treatment, psychotherapy, and or pharmacotherapy. If you're a prescriber or a mental health provider, you want to think about medical comorbidities when it comes to best treatment options. Pharmacotherapy might not be advised in certain situations, and sometimes there is the caveat for certain populations that certain types of psychotherapy may not be super useful. For instance, certain types of psychotherapy that are more talk-based or based on new learning are going to have are going to be less effective for folks who have significant cognitive impairment who maybe have dementia. So I'm not a prescriber, so I won't spend too much time here. But the first line therapy typically for antidepressants is the SSRIs, but in particular sertraline, and I'm not even going to try to pronounce escitalopram. Sorry about that. But as a non-prescriber, I don't see my job as thinking about what type of pharmacotherapy to initiate. I'm usually on the lookout for maybe some medications that have been prescribed or being considered that go against recommendations from the American Geriatric Society in the Beers Guide. It is an excellent guide. There's a 2023 update that can help improve safety and quality of care for older adults, given that some medications are contraindicated in older adults, and some might even have anticholinergic properties, which can negatively impact thinking abilities. So a little bit more about depression in older adults. It is important to try to monitor for depression. There is increased medical morbidity. As increased medical morbidity exists, there are rates of depression that can get quite high, especially in post-critical care, as high as 37%. Also, are some studies that suggest that if someone already has cognitive impairment, they may have a less robust response to antidepressants. It doesn't mean you shouldn't try them, or a little bit of help might not be useful. Another thing that's there is that it's important to continue to monitor for cognitive changes, because depression that develops for the first time later in life has been shown to be a red flag for preclinical dementia. Also, not necessarily the same thing as depression, but do keep in mind that pretty consistently it's been shown that suicide rates are higher in older adults. I realize I still have the word elderly there. I need to take that out. And also, suicide rates can be higher in certain other populations, white Native American peoples, males, and veterans. But this is not necessarily true across all regions of the country and in all communities. So here is a table that kind of highlights some of the common features across all 3Ds, as well as some hallmarks or features that might be more typically associated with one of the 3Ds. Okay, with all of this, I bet you're all feeling like totally, it's so easy to distinguish one of these from the other, right? Well, guess what? Unfortunately, there can be overlap in syndromes. I pulled just a few articles. Sorry, let me put this up here to highlight some of that. So for instance, a condition that's called DSD, delirium superimposed on dementia, those estimates range 22 to 58%. That's really common. And unfortunately, when someone has dementia, it can be even harder to pick up on those signs of delirium. In older hospitalized patients, a study from 2009, so this is a little bit of an older one, but it's got a really nice sample size. Delirium and depression occurred in 5% of folks, delirium alone in 8.5%, and depression alone in over 26%. When folks had that overlap syndrome, they had much higher odds, significantly higher odds of 1-month functional decline and nursing home placement or death a year later. In dementia, the rates of depression have been a broad range of reported rates, but anywhere from 20 to 86%. So I wanted to use a case to kind of highlight a few things moving forward here. This is Joseph. Obviously, it's not a real case, but hopefully this will be illustrative. So he's a 66-year-old male veteran. He's been divorced for a couple years from his second wife. It wasn't a very long marriage. It was less than 5 years, and he's new to the primary care clinic. He moved to be closer to his daughter, his only child, and he lives independently in an apartment. He comes in with his daughter, and she is concerned. He sits around all day and forgets what I tell him. In terms of his premorbid medical history, he has diabetes and hypertension, both of which they report has had historically good control. So we have his daughter as a collateral, but she's not necessarily a collateral that can tell us much thinking back until he's just moved here, right? But we are still very lucky to have her as she's a connected, invested, close family member. When you asked Joseph about whether he has any concerns, his initial response was, "I'm fine." And that's it. Okay. So when labs were checked and blood pressure, it was clear that both glucose and blood pressure are actually out of range. And so what might jump to mind is he taking his medications, insulin is prescribed? That for some providers, if they're not thinking about red flags of the 3Ds, the response might be, well, gosh, we really need to up his insulin, or we need to increase dosages on these antihypertensives. But that would be a problem for Joseph. Another red flag here, he says he misses his wife, his ex, and he doesn't have any friends here. So you're going to ask even more. You notice also as a provider that he does not seem cognitively sharp, and the "I'm fine" seemed rather disengaged. So what are our next steps? You've picked up on the red flags, but you don't know, is it depression, dementia, or delirium? So it's time to initiate a workup. For identification and screening, I would like to highlight some tools. Totally biased here with a cognition education work group that I currently chair, sorry, just newly. We have developed a 3Ds pocket card that helps distinguish between these three. I'm going to show you. There's talking about delirium a little bit more. Oh, I'm sorry, I should mention. So there's the panel for delirium on the pocket card. Let me just go back one more time. It's actually the smallest portion of the pocket card is on delirium. But that's why we went and developed a delirium reference guide that is specific to delirium in ambulatory outpatient settings. So let me just talk a little bit more about delirium first. In this pocket card, there is the BCAM, that's the brief confusion assessment method. This algorithm flowchart from Vanderbilt is really, really nice, and it is reproduced in the card with permission. So please don't take screenshots of this and reproduce it elsewhere. But it's super helpful for coming up with whether it's likely that there's delirium present. Also in that delirium specific pocket card is the modified Richmond agitation and sedation scale. The original RAS was developed to assess sedation and agitation in an intensive care unit. So the MRAS is a VA developed instrument to slightly modified to be used in those non-ICU settings. So when you're working up delirium, really important is for any of these is having some collateral source of information, but really considering the whole clinical picture, because there's a really broad differential for delirium. And here is the med students acronym for remembering common causes of delirium: infections, withdrawal, acute metabolic disorder, trauma, CNS pathology, hypoxia, other types of deficiencies, either vitamins or nutrients, endocrinopathies, acute vascular changes can cause delirium, toxins or drugs, not surprisingly, as well as heavy metals. Well, the good news for Joseph's workup is that it was negative. So what's our next D to tackle? Let's think about depression. Probably the number one take-home thing I want to say is that you don't have to be a mental health professional to ask about symptoms of depression. What you do want to do, though, is use recommended tools to guide you in how you ask about it, and then have a plan for how to triage should you get a positive. Always remember screening for depression is covered by Medicare Part B. I will mention the PHQ-2 and the PHQ-9. These are both well validated, free, and commonly used. What I won't highlight today is the Geriatric Depression Scale. It comes in either a 30-item version or an abbreviated 15-item version. That's what I use personally in my clinic. Also, if you are an employee of the Veterans Health Administration, most of us are expected to add the Columbia Suicide Severity Rating Scale, which is a screening measure for suicide risk. Let me just hit on the PHQ-2. Well, it's quick. And it's a self-report screen. It could be appropriate for your setting, especially a quick screen in the front lines of primary care. And the question is, over the past 2 weeks, how often have you been bothered by these problems? The first one is little or no interest or pleasure in doing things, that anhedonia. And then very directly asking, have you been feeling down, depressed, or hopeless? And it's a range of points here from not at all to several days to more than half the days to experiencing this nearly every day. So a score of 3 or greater merits completing the PHQ-9. Okay, here's what it is on the next slide. So you can see here the first 2 questions are the ones from the PHQ-2, but now we just add in 7 more questions using the same scale. And you can see here that we hit at some of these more physical, behavioral aspects, hits on feeling, even cognition, concentration, moving, speaking slowly. And then number 9 is thinking that you would be better off dead or that you want to hurt yourself in some way. So a score, a further suicide risk evaluation is recommended if the total score, and that should say score, not C-core, is greater than 10 and or that response to number 9 is anything greater than 0. Okay, so thinking about situations where that number 9 might be triggered or someone has a really high score, even if your clinical setting doesn't require to use the Columbia, I do think it's a nice tool that asks about suicidality and desires to be dead, which by the way, doesn't always track with depression. I have had folks who had a very detailed plan for how to kill themselves who did not actually score in the severe range on my depression tracker. There were other things at play. So for the suicidal ideation questions, there's the wish to be dead, non-specific suicidal thoughts, active suicidal thoughts with methods but no plan, active suicidal thoughts with intent and without plan, and then active suicidal thoughts with specific plan and intent. And so they ask about it, whether you've experienced it over the past 1 month. Sorry, I realize I'm moving my cursor on the wrong screen here. Whether you're experiencing it just recently or whether you've ever experienced it in your lifetime. There's research that suggests that having experienced these types of things previously, even if not experiencing them now, can be associated with more increased risk in the future. So Joseph denied current suicidal ideation or past suicidal ideation. So he really was basically a 0 on this. Okay. So Joseph has endorsed some depression, but Joseph is not suicidal. He does not have delirium. But now we want to think about whether there are any red flags for dementia. So I do recommend what's sort of termed the red flags method. There's not necessarily any reason to send everyone over a certain age for a full workup, but when you get that red flag, don't ignore it. It's a great time to maybe at worst get a little baseline info, okay? And at best, it's you can catch something early, and folks are then able to use all 4 M's in their planning and in their care. So here are some of the red flags that I look for. I'm not going to read through all of these, but you can see how someone suddenly failing to keep appointments when they didn't previously no-show, changes in weight, caregiver or family members being deferred to for the answers to all questions, and of course being attuned to what the patients themselves or their loved ones may report. So I've talked a little bit about, okay, so red flags, maybe you send them off to specialists, but in a non-specialist setting, what kind of information can you gather that could be helpful to either reassure someone or to trigger your frontline monitoring of them over time, or maybe such that you really want to get them into a specialist or do more advanced workup faster? In terms of cognition, I do think that the mini cog is a really nice screening tool. It's the quickest. It's maybe a little bit dirty since you really cannot use it, do not use it to diagnose dementia, but it can be done in less than 5 minutes. All you need to do, get the person's attention and say, I'm going to say 3 words that I want you to remember now and later. The words are banana, sunrise, and share. And then you have them repeat them back. Please say them for me now. That's not scored. That's just to get them into their head. If they can't get them all the first try, you're going to repeat it and you're going to give them at least 3 tries to get all 3 words. Next, you're going to say all these phrases in order, asking them to draw a clock, put the numbers in, and then set the hands. And that would get 2 points for a clock without errors, and it's 0 for any error. They only get about 3 minutes. If they can't draw that clock in 3 minutes, you should discontinue. And that's when you ask, what were the 3 words I asked you to remember? In this case, each word gets 1 point. So the author's recommended scoring, there's only 0 to 5 points possible, is that if someone only gets 0 to 2 points, that's indicative of possible impairment. And then they say 3 to 5 suggests no impairment. Personally, I don't really love the cut point because I think that if someone draws a bad clock, especially if they do all the numbers really tightly in order and maybe even keep going up with numbers, they might only lose 2 points and get a score of 3, but that is definitely an abnormal clock. If someone has trouble encoding the words and can't get them after 3 tries, that's a red flag as well. So there's certain situations where a score of 3 or 4 might not suggest no impairment. So here's just, this will be in a handout that will have just sort of more information on that scoring. Here's what's required in terms of elements for the clock. What is interesting to me is that this clock technically would be considered normal, but you can see that this person is sort of not doing a good distribution of the numbers. And so as a clinician, I wouldn't love this. It would get a full score, but I would still maybe do some more checking on visual spatial abilities and attention. If someone refuses to draw the clock, that is considered abnormal as well. Obviously, if someone has vision problems, this is not a good test. So there are lots of other brief cognitive tests out there. They are brief, but they are not as fast as the mini cog. I think that both the SLUMS, the St. Louis University Mental Status Examination, and the MoCA, which stands for Montreal Cognitive Assessment, are good 30-point examples. Here's a picture of what the SLUMS looks like. Here's a picture of what the MoCA looks like. There are other measures out there. Some folks use the Blessed Orientation and Memory Concentration Test. I think if my memory serves, that is reverse scored, where getting points is bad. So sometimes I don't like that one because it's really easy for that to get misinterpreted in chart notes or by people reading quickly. There's also the MACE or the ACE3, which is the A stands for Addenbrooke. It was developed in Australia, but there are US versions. Those can be used. So a little more information about the MoCA, which is my personal favorite. It is available at the mocatest.org website. It is more sensitive than the old school mini mental status examination, which many, many years ago got copyrighted, and now you have to pay for that. So while the MMSE can be paid for, and it's not a bad tool, it's actually not as sensitive or specific as the MoCA. The MoCA does have a lot of research behind it. It comes in multiple English versions in case you're in a situation where you need to test someone maybe multiple days in a week or over a short hospital stay. It also comes in at least far more than 25 other languages, although I would caution you that if you don't speak that language, and aren't fluent in it, administering the test in a foreign language is not usually recommended, nor is using family members as interpreters because you don't know that they're getting it right or not, or if they're helping their loved one. Also, the MOCA has a blind version, which also, of course, works for telephone. There's also a telemedicine version with visual stimuli that you can use in telehealth, telemedicine healthcare. However, training and certification is required for this. That doesn't take very long. I think the training is about $150. There are group rates. And in certain healthcare settings, the institutions actually have contracts set up so that people can do the training and certification that is required. The slums, what a great name, but it's far from perfect, but it's acceptable for many populations. It is always important with any of these tests to use the standard instructions. So I think the fact that so the slums has both good news and bad news. It's free, which is great, and no training is required, which I say sort of yay, because the truth is you need some training to administer these tests. I'm not saying you need to be a clinical psychologist, but you can't just pull the sheet off and administer it and do it well. The slums has a Spanish version, but please note that it's Puerto Rican Spanish. That may not apply to other Spanish speakers. And I have to laugh, they have a Canadian version, which instead of state has province, and instead of the city of Chicago has Toronto as the city. What I would say that's a flaw, and it's because VA folks are who developed this, and it's hard for us to get funding to do this sort of thing and time out of our FTE, is that it had a really small, limited research sample that it was based on, and there has not been much follow-up research that's published for the slums. So therefore, there's certain bias that's both cultural and socioeconomic. It was primarily, the research sample were older white male veterans in the St. Louis area. It also does not have an official adaptation for telephone or telemedicine, but there I would say don't let that hold you back. For telephone, you can just prorate it. And actually, it prorates better than the MOCA with a total score available of 26, whereas the blind version, the telephone version of the MOCA, you only have out of 22 points for that. For telemedicine, it's also actually pretty easily adaptable to give yourself those visual stimuli that you can share. Okay, what is the utility of brief cognitive tests? Maybe I should have told you that first, right? The answer is not to diagnose a cognitive disorder like dementia based on someone's score. However, it is good for getting some objective information. I would say, number one, for anybody to obtain a quick sense of their global mentation at that time, not necessarily forever, but at that moment, to potentially identify some cognitive decline early. And the benefits of that might be early introduction of supportive elements, whether that's addressing reversible influences, assisting with care planning, maybe even motivating patients towards positive behavioral change. And also, if you're sort of with that and then other pieces identify early stage dementia, it might be worthwhile for the early introduction of a cholinesterase inhibitor or other thing like that. And then lastly here, I think it's really important that it can be used to identify whether it's important to question if someone has decision-making capacity. If someone is in the position of needing to make, without any support from a loved one or friend, a big decision about their medical care, and they are scoring a 10 out of 30 on one of these measures, that's a red flag. And you'd want to help get some other evaluation on board, maybe talk to ethics committees, things like that. So in terms of cognitive screening or these brief cognitive tests, what's the meaning? I do think it is important to understand that there are different ways to interpret scores and appropriate populations that they can be used with. Note that there is limited detection, sort of that sensitivity and specificity is less for those who are sort of outside the average range, folks whose pre-morbid thinking abilities were either at the very high end of the spectrum or the lower end. For folks who've always had a learning disability or who had low education, there might be some limitations there. Obviously, if someone has hearing and or vision problems that could be having an impact on their score, keep that in mind. And of course, limited hand function, whether that's due to essential tremor or some other injury, they may not score as well on these things. Brief cognitive tests are poor as standalone measures. I'll probably say it 5 more times today, but it's always important to get some collateral input when you can, and to think about what other risk factors there might be and what's the context. So let's see. Joseph's MoCA score, gave him a MoCA, was 25. I just want to let you know that's kind of in the gray zone. It's not a number where you can say you are just fine, no big deal. It's also, though, not terribly alarming. I haven't provided you with any information about Joseph's occupation or Joseph's educational background. So, you know, that's sort of in that gray zone. All right, so I've talked about warning signs and ways to screen or do brief tests for objective changes in cognition. But what other important piece of that puzzle for a dementia diagnosis or even consideration is left? People could throw it in the chat if they want to. If you need to like reinvigorate yourself with the talk, throw that in there. And then I'll tell you, it's function. You can have objective cognitive decline, but if it's not affecting daily living, it does not meet criteria for a dementia diagnosis. So I particularly like the functional activities questionnaire, and we have that on our 3Ds card that our group developed, but you can get it in many other places. There's all sorts of different instrumental activities of daily living questionnaires out there, but I like it because it just has these 10 topics that I think are pretty or somewhat universal. I should not say they're universal in the United States that independent adults sort of need to be able to do. I won't read them all to you here. There's scoring for each item. It is important. I like that this functional the FAQ has a different, it acknowledges that there might be something someone has never done. For instance, someone may have never done the cooking, but it asks, oh, never did, but could do versus never did, but would probably have difficulty, right? If someone loses their partner and that was the person that did all the cooking, it might reveal that they now have some deficits and are not able to learn how to cook for themselves. So they start just only going out to eat, things like that. So you sum the scores and you get a total. It ranges from 0 to 30 and a cutoff of 9, which means you're dependent in 3 or more activities, is where for a lot of people that tipping point is. For me, I want to know if there's anything that they couldn't do or would have difficulty doing and try to dig in a little bit more. Joseph only had a score on the FAQ of 3. And he was just, for him, he was actually getting a score of, I believe it was 1 in 3 of the categories. It was for that he's just finding some things more difficult. He's still doing his taxes, he's still paying his bills, and he still is remembering his appointments, and he's doing them without assistance, but he's needing more reminders and structure to get them done. Okay, so another thing is to always remember that dementia is a diagnosis of exclusion. That's why I just keep trying to bring it home that it's important to think about other risk factors or health conditions or mental health conditions that could be causal or maybe even just or somewhat contributing to the loss of independence or changes in independence. And so our 3Ds card has this one panel that just comments on a few of the additional factors that can impact thinking and daily function. And we've even developed some healthy brain booklets and materials to help people work on some of these. So some of the risk factors that I think are particularly important to manage and or avoid under medical conditions, it's that management of high blood pressure, cholesterol, diabetes especially, and sleep apnea, as I mentioned, is a particularly insidious and common cause of cognitive changes. Unfortunately, if sleep apnea is severe and goes on untreated too long because of changes in the brain with lack of oxygenation during sleep, there can actually be some permanent damage. So sometimes education is really helpful for folks that are having a hard time really trying to habituate to that CPAP, right? So this is, and then under behavioral factors, thinking about nutrition and diet, maybe reducing alcohol or cutting it out altogether, tobacco, of course, and increasing exercise and physical activity, trying to manage stress. We can't usually get away from all stress, but how it's managed is often can have, if it's less well managed, it can have a really negative impact on our thinking. Also, increasing socialization or at least social connectedness. You don't have to be a social butterfly, but having some relationships and interaction with others on a regular basis seems to be very important for brain health. Okay, let's see. This is not an exhaustive list, just to make sure. So I have this sort of suggested 3Ds action plan. The step one is always that rule out, right? You've got some indication that there's something going on objectively with mentation. And so you use the frontline tools, you use history, you use collateral information, a physical exam, maybe some blood tests to try to help you rule out things that could be going on. And then depending sort of what comes from that, you may just sort of be in a monitoring phase, where you're using frontline tools on a regular basis to catch any new signs or change early. Maybe the rule outs threw you all the way forward to step three, where some aspects of more in-depth evaluation were important. That could be also if problems persist or worsen, things like brain scans, whether it's a CT or a brain MRI, maybe additional labs, maybe referral to specialists. So Joseph, back to Joseph. His evaluation, if you didn't catch it on the slides before, delirium was ruled out. Depression is present and treatment was initiated. But dementia is sort of a TBD at this point, right? He has that 25 on the MoCA. It's not necessarily something that has to trigger like a full neuropsychological evaluation with someone like me, because he's doing okay independently. Now, if that's a resource that you have readily available, I would say that that's a score that I would take a referral for someone with a 25 out of 30 in Joseph's situation. But it's also a score where you could kind of wait and see if depression treatment is effective, but he seems to continue to decline in any way, whether it's functionally or even on the objective tests. That would be a really good time then to, with that evidence, push forward for more specialty evaluation. Okay, so I've got this totally pirated Gary Larson cartoon. It's for educational purposes only, of Superman in his later years, who is standing at an open windowsill and is not sure about what he was doing when he got up there. So that's my attempt to end with a little bit of levity. Is this a red flag for dementia? Is it a red flag for delirium? Is it a red flag for depression? Well, I hope you appreciate at this point that it's a red flag for sure, but it could be any of the above and maybe more than one. And hopefully you'll feel a little bit more, and then you've got a few more tools or features and references and knowledge at your disposal to tackle that. So thank you so much for your attention. I've ended a little bit early today. It means I'm probably talking too fast, but the good news is that means that I have some time to answer questions. I have my contact information here in case for some reason you do need to jump off, but you do have questions. I also have my colleague Julie Moore's email address. She is the person who can help facilitate sending out some of those pocket cards, either the 3Ds card or the delirium reference guide, if you're interested. She needs information like who you would be sending, who would you be using them with, how many you want, and a mailing address that you can get a box at, no post office boxes like that. So with that, I wonder if there's a way. Oh, how cool. I realize everyone is now seeing the chat probably in more than one place, but this way I can leave these contact information up for just a little bit. And I also can go back in my slides if I need to. Dr. Cochran, did you have any questions to ask me up front before I start sort of scrolling through?
I did get a question from Sheila. She was asking, how do you get training for the slums?
So the slums, that's the challenge with the slums. It's some people would say it's a good thing that there's no required training, and some would say it's a bad thing. There's actually a couple YouTube videos for training for the slums, excuse me. They are pretty easy to find on YouTube with a search for slums. I can also, I'm trying to think, I have a talk that's all about brief cognitive tests, and in that I have the links. How about this? You have my email address. If you have trouble finding those YouTube videos, and each is like only, there's two key ones. You don't need both, probably. One is just much more didactic and assumes some familiarity with these types of measures. The other one is a little bit more informative. I think it's still less than 15 minutes, and it does a little bit more of like showing a back and forth between a provider and a fake patient. So I personally recommend both of them if this is at all new to you. But once you've learned a few of these tests, you'll find that some of the basics of standardized administration hold true across them. I mean, we're always going to get a patient that throws us a curveball. And in that case, if you have to break standardized administration, I just recommend document, 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 right? I put the score in, but I explained that, the fire alarm went off twice while we were trying to do it, or things like that. Yeah.
How soon can the mocha or slums be re-administered after it's been done? And that
Ah,
leads to another question about how often should you check the slums? Kind of the
So
same.
it always depends on the setting. The slums does not have an alternate version in English for US sort of populations. So I do not recommend administering that in an inpatient setting or where you would need to do it in less than 3 months again. But it's certainly fine for every 6 months or once a year. Now, a few savvy people might start to realize you're going to ask them regularly and go home and write things down and then prep. But usually they'll cop to it. The mocha has those multiple English versions that they have research showing sort of how that test retest reliability looks with the different versions. And so those are where you could use them more frequently than so once a day or every week for a month. Basically, the rule of thumb is even with the mocha, that if the testing is even 3 months apart, you can still use the same version. And in fact, apples to apples, I actually prefer, especially if it's a year apart, to use the same version. And so the question, how often would I recheck the slums? Well, it does depend on the environment, the mocha or the slums. If I was in a primary care clinic and say Joseph had gotten that score of 25 and I was going to do a check-in with him, say in 6 months, let's say 3 months, to check on the effectiveness of trying that SSRI and to see if he's making some friends and whatnot. I might not re-administer it then unless there was a new red flag, but at a 6 month checkup, I definitely would. I think that would be worthwhile, especially in a situation where he's now not so lonely, mood is better. Other things for him have stabilized. He's not just post move, to make sure that it's not going down, right? And you wouldn't expect a lot of decline in that amount of time. But even like a 2 point decline in 6 months, I'd probably go ahead then and try to initiate a little more workup, whether it's a neuropsychological evaluation or a brain MRI or something like that to kind of get more information.
Amy is wondering, what are your thoughts on the Allen cognitive levels screen?
Well, this is awesome. I will be writing this down. I am unfamiliar with the Allen cognitive levels screen. So, Amy, I guess I don't think you're able to unmute yourself because, of course, we've had times where there's like someone steps away and we get their like waiting music on that we can't turn off. Oh, it's something that an occupational therapist would do. I apologize. I am not familiar with that tool. I think that there are different types of measures that my allied health colleagues use, and it's kind of good that we don't all use the exact same thing. Occupational therapists, it sounds like, use this one. Speech language pathologists have a few, we have some overlap in some of our measures, but they've got a few things that they use that I'm not familiar with. So unfortunately, I don't get to have an opinion on something I don't know anything about.
So, Emily, since there's a little bit of time, I hope you don't mind my asking a personal question or a question of personal interest to me. And that is that even older adults, but certainly folks who are moving into their older adult years are using digital clocks
Yeah.
now, and analog is not kind of as readily, retrievable in a brain. Are there discussions about the clock drawing test in
So
that
what's
regard?
really funny is that these were discussions back like what now seems like eons ago, even when I was in training. But the truth is, the analog clock has not been totally replaced by digital clocks, and kids still are learning analog clocks in school. And for most, the older adults that we're working with, unless their culture is sort of not time oriented, that's that well-learned information. Someone should be able to do the clock. Yeah,
Okay.
I hear you. I hear you. But you know what, Barb, if you came into my office and you had trouble drawing a clock, I'd flag you on it. And if a 30-year-old came into my office and had trouble drawing a clock, I'd flag them on it too. Um, Now, is it the basis for a diagnosis? Heck no. But
Yeah.
it definitely is. It's important to these that sort of falls into that well learned information.
Thanks. Okay, I don't see other questions. This is just great. I actually really appreciated sort of the distinction between, normal aging and red flags and the dementia, delirium, depression distinctions, because they are sometimes a little bit difficult to make those choices.
I think it's really difficult. I think I as a neuropsychologist, what I get, it's not that I have some magic ability to distinguish depression from, mild cognitive impairment. What I do though is I get the benefit of time. I have also, so I work with people for longer, giving multiple measures. I can help them get over test anxiety. I tend to engage them so deeply that they kind of have to set aside that part of their brain that was sort of maybe consumed by depression. And so they tend to perform actually quite well on cognitive tasks. In fact, they might even perform better on the harder versions of it. So a lot of my tests, they start off easy and they get harder and harder until people fail, which sounds really, really mean, but it's the only way to see the full breadth of what someone can do. So it's really not unusual that someone with some depression that seems to be affecting daily living or that they're thinking they're having memory problems for, they actually do better on harder level items because they're more engaging for them and they can't they sort of ramp up for it. So yeah, but the key important thing is whether it's mild cognitive impairment or depression, they're both things that we need to try to identify. um, and they're both things that cause distress for people and or their loved ones. And so it's that catching those indicators, those red flags or even like pink flags, that's so important when we work as a healthcare team.
And just a heads up to everyone, we'll be having a talk later on in this series on mild cognitive impairment, in part thanks to um, Dr. Trittschuh's connections and her participation on our planning committee, as well as a talk next week on the whole person in dementia, I think it is, which will go into the different types of dementia. So Dr. Thelke will talk more specifically about the different types of dementia. So lots coming up. This has been a great preview.
I'll
Thank you.
even make a plug for I'm going to co-present with Stephen Bielke later in this series. And for that one, we are going to talk a little bit more in depth about Alzheimer's disease and Alzheimer's dementia and some of the newer therapeutics there, and kind of really build on that a little bit too. So I can't believe I'm plugging my own talk. It's so
Well,
tacky
and
of me.
thank you for mentioning that, because I wasn't tracking on that as much as I was some other things. And yeah, that will be invaluable because it's going to be the latest sort of research and clinical practice focus for Alzheimer's disease, and should be a very valuable talk. That's on May 2nd. All right, everyone, thank you for joining us, and we will see you next week. Dr. Trittschuh, as always, thank you.
Thanks, everybody. Feel free to message me if you have questions you didn't want to ask. Front channel. Take care.